All right. Looks like it's time for us to go ahead and get started. Hello, everyone, and welcome to this month's Northwest ATTC webinar. I'm Jennifer Verbeck, and I'm your host for today. We're excited to have Dr. Joanne Sparrow presenting for us today on tailoring treatment for clients with prenatal alcohol exposure and fetal alcohol spectrum disorders. Next slide, please. A couple of quick housekeeping things. First, if you have any questions for our presenter, please type them into the chat box at any time, and we will try to answer as many as we can at the end of the presentation. Next slide. You'll also be getting an email at the end of today's webinar that has a link to a survey in it. Please take that survey as it helps us make sure we're bringing you the content you're most interested in, and it also helps us continue offering free or low-cost events such as this one. That email will also have a link to download the slides from today and a link to our website where you'll be able to find a recording of the webinar as well as some resources that we'll make available to you, and that should be available later this week. Next slide, please. Additionally, we'll be sending everyone who attends this live webinar a certificate of attendance. It takes us about a week to get those out. You don't need to do anything to get the certificate unless you're watching this in a group. If that's the case, please have someone in the group email us within a business day with the names and email addresses for everyone who wants the certificate. And you'll see our email address on the slide. It's northwest@attcnetwork.org. Next slide.
Whoops.
Now on to our webinar. I would like to take a moment to acknowledge our partners at the Addiction, Drug, and Alcohol Institute's Fetal Alcohol and Drug Unit program. We had Dr. Susan Stoner, who helped arrange this month's topic in collaboration with Dr. Sparrow. I will include a link to the FASD unit website in the chat box if you would like to learn more about their program, which disseminates research information and provides consultation for individuals affected by prenatal exposure and FASD. I'm also pleased to introduce our speaker today. We have Dr. Joanne Sparrow, who is a clinical psychologist in private practice, currently licensed in Washington and Colorado. She works primarily with adults who present with histories of complex trauma, post-traumatic stress disorder, mood and anxiety disorders, as well as substance use disorders. And with that, I'll go ahead and turn it over to Dr. Sparrow. Thank you so much for joining us today. We appreciate your time.
Well, hello everyone, and welcome to today's talk. Meg, I wonder if this would be a great place to introduce the polls, please. I just have a few questions about who I am speaking to, kind of curious about who is out there. And as you are answering the questions, you see things are coming in quickly. I've got a lot of social workers, mental health counselors. I love that I'm seeing people from the medical profession coming in. It's really lovely. I've got substance abuse counselors, teachers, educators, others. Lovely. Okay, new to the field. So some people come in with much knowledge, a lot coming in with some knowledge. People new to the field, and about 50-50 split in terms of people currently working with an adult with an FASD. Okay. So it looks like we're almost there. Jen, does the poll shut off once everyone has responded, or?
I believe so. Meg can.
Yeah, as soon as I think I shut it off manually. So just let me know when you feel like you've got a good collection. Looks like 70 of 78 people have participated. So that's probably good.
Yeah, no, that's
Right.
that. So thank you. Yeah, it's really lovely who is joining us today. So we will stop the share, and let me get back to my PowerPoint. All right. So I would like to begin my talk today by acknowledging that the land I live and work upon is the traditional territory of the Muckleshoot, Suquamish, Duwamish, Nooksack, and Northern Lushootseed tribes within territories of the Coast Salish people. I honor and respect the stewardship of this land by their descendants, past and present, and this acknowledgement does not take the place of authentic relationships with Indigenous communities, but serves as one way to honor the land I am on and to resist erasure of their history. So thank you for letting me start with that. In addition to working with adult clients with complex trauma histories, I also just want to share a little bit about the work I do when I'm wearing a research hat. I work at the Seattle Children's Research Institute with the developer of the Families Moving Forward program, Heather Carmichael Olson. I offer Families Moving Forward an evidence-based intervention to support families raising children who are affected by PAE, with or without a fetal alcohol spectrum disorder, in my private practice. And in my volunteer capacity, I am a member of the Executive Council for FASD United, which is our national organization dedicated to FASD education and advocacy. And I'm also president of our state affiliate, FASD Focus Northwest. So this population of clients is very near and dear to my heart. So today, just briefly, my plan is to provide you with a brief overview of the impact that prenatal alcohol exposure can have on the developing brain. And this is really just as a way of helping to underscore the fact that FASD is a brain-based disability. And I want you to think about that and sort of use that as sort of home base to come back to in terms of when behaviors, our understanding of behaviors gets kind of challenging, come back to, is this something related to the brain-based disability? I'll move into providing a brief overview of assessment, diagnosis, screening, and highlight the differences between primary outcomes and associated difficulties. And then finally, I'll get into tailoring treatment. So utilizing a neurodevelopmental lens, which is really important, as is ecological systems theory. I'll explain that when we get to that part of the talk. These are a way to guide and inform your assessment, diagnosis, treatment planning processes, and intervention. Lastly, I wish to acknowledge that there are several topics I will not be able to address during the presentation. Issues pertaining to children and adolescents, sex and gender related differences, psychopharmacology and FASD, concerns regarding FASD and our Indigenous communities, which needs to be considered within the context of things like colonization, colonialism, intergenerational trauma. So these are all very, very important topics and need to be addressed separately, hopefully in future presentations. Before we begin, I do want to take a moment to reflect on the importance of cultural humility and acknowledge the reality that many of our assessments, diagnoses, and interventions have been developed using a white informed lens. And in order to do no harm, I believe that it is important to acknowledge the cultural context within which the people we serve live and the ways in which this context influences and intersects with the many areas of that individual's life. I feel that by acknowledging the importance of culture, we also create space for the strengths and alternate approaches to healing that may be overlooked or have been minimized when we don't think outside of a white informed lens. I also want to acknowledge that language matters and language is powerful, and it can fuel implicit and explicit bias and perpetuate stereotypes and stigma that harm the clients we work with. As a field, we are recognizing that the language we have been using has been harmful to individuals. And a perfect example of this is the tagline, FASD is a 100% preventable disability. So I invite you to think about language and to look at the language guides that I've included in the resources section of this presentation. And then lastly, I just want to take a moment to acknowledge issues related to access to power and privilege. And as you move out of the center of the circle, notice how an individual's access to power and privilege begins to diminish. Please notice who has the greatest access to power, those of us closest to the middle, and notice that the individuals and the families you serve may be situated further from the middle, and think about how this impacts many things such as access to basic needs, food, housing, safety, and access to things like education, mental health care, and medical care. So, what is FASD? Want to take a moment or two to hear from Miles Himmelreich, who is a motivational speaker. He is part of the Adult Leadership Collaborative, and he draws on his experience of living with an FASD.
Hi, my name is Miles Himmelreich, and I'm going to talk to you today about what is FASD. FASD stands for Fetal Alcohol Spectrum Disorder. Many people may have heard of FAS, Fetal Alcohol Syndrome, or FAE, Fetal Alcohol Effects. When I was adopted around the age of 3, the home I went into, they were informed that I had, at the time, the diagnosis of FAE, Fetal Alcohol Effects. A few years ago, it was changed to Fetal Alcohol Spectrum Disorder because it's a spectrum, and many people are affected differently. How does one get FASD? Well, that's when the mother drinks alcohol during her pregnancy, and then the child is born with Fetal Alcohol Spectrum Disorder. Fetal Alcohol Spectrum Disorder affects the brain, affects the body, affects the individual in so many different ways. We need to understand the diagnosis of FASD to understand how to support the individual. Once we can do that, then we can start to have more success and see the individual accomplishing things in their lives. If we don't do that, we're going to continue seeing individuals with FASD as people with bad behaviors. And we need to, as a society, understand that we can't look at people and think, oh, you have FASD, that's so sad, that's too bad, you're a victim who suffers. We need to understand that everyone's affected differently, that they need different supports, and they'll have success in different ways. Once we understand FASD as being brain injury that affects the whole body, then we can look at things differently and understand it's not behaviors, it's the way my brain works. It's not that it doesn't work, it just works differently. And if I can find those ways for my brain to work like everyone else, then I'll be successful like everyone else. But that's not always the case. Because my brain works differently, I'm gonna have different successes. It doesn't mean I won't have success, it just means it might look different than other people. And as long as I understand that, I can get to a point where I can understand FASD, become accepting of FASD, then I can understand myself and become accepting of myself.
All right. So Miles mentioned several important points that highlight the need for providers to really become FASD informed and understand that FASD is a brain-based disability. With that knowledge, we can then move forward to tailor our interventions accordingly. What I want you to do is take a moment now to reflect on the points listed here on the slide, and think about any clients you have been working with or have worked with in the past who may demonstrate one or several of these challenging behaviors, and notice what comes up for you. These clients can be confusing, frustrating to work with. Their behaviors can leave us scratching our heads, and it becomes easy to think that the client is being oppositional or isn't working as hard as we are. So I invite you to hold thoughts and feelings that come up for you, and notice what changes when we approach our work with clients with FASD and PAE using a neurodevelopmental lens that helps us see things differently. So really briefly, the umbrella of diagnoses that are part of the spectrum, we know from both the animal and human research literature that alcohol is a powerful teratogen, and that fetal alcohol syndrome, or FAS, is a permanent birth defect caused by alcohol consumption during pregnancy. The condition is now recognized as a spectrum disorder, a spectrum of disorders, right? The most recognizable is the full syndrome, which is diagnosed on the basis of a number of distinct facial characteristics, impaired growth, cognitive and behavioral abnormalities, and a confirmed history of exposure. We also have partial FAS, where individuals demonstrate, they exhibit FAS without the growth deficiency, or most but not all of the facial features. We have static encephalopathy, alcohol exposed, where individuals demonstrate severe cognitive and behavioral impairments, but don't demonstrate the facial phenotype. And then we have neurodevelopmental disorder, alcohol exposed, where individuals don't demonstrate the facial phenotype and do demonstrate moderate cognitive behavioral impairments. This slide represents the numbers regarding prevalence rates of FAS here, FAS in the full spectrum here in the US. What I want you to notice is that the prevalence rates tend to be higher in higher risk populations. And there are a number of reasons for that I won't be going into in this talk. Basically, the takeaway from this slide is this number here, right? The national rate could be close to 50 per 1,000 or 1 in 20. And so if one individual in 20 is affected, it is important to have PAE and or FASD on your radar as something to consider and maybe begin having a conversation about. In terms of factors to consider, while all the diagnoses encompassed under the umbrella are linked to prenatal exposure, the effects of that exposure vary widely and are influenced by a number of different factors. Because of the differences across these factors, each person will demonstrate a set of challenges that are unique to them. And so the takeaway message here is that when you meet an individual with an FASD, you have met an individual with an FASD. And it's really, really important to begin thinking about ways to tailor interventions and sort of move away from a one-size-fits-all kind of model. I also want to note that not every birthing parent who consumes alcohol will give birth to a child with an FASD. That being said, however, science has yet to determine a safe level of exposure. Really briefly, this table lists the 4 domains evaluated using the 4-digit diagnostic code that was developed here at the University of Washington. So I just want to give a shout out to the work being done in our own backyard in terms of helping to further diagnosis. Want to be really clear that FAS is the only diagnosis considered to be an official medical diagnosis. And that tends to make things a lot easier for folks in terms of opening doors to access service. Unfortunately, individuals who present with static encephalopathy, neurobehavioral disorder, may be as impaired, if not more so, than an individual with the full syndrome. However, these individuals oftentimes do not receive services because they don't have the official medical diagnosis that can open certain doors. And as a result of not receiving supports, people understanding that they may need accommodations to succeed, we tend to see higher rates of associated difficulties in this population. And then just notice that all of the diagnoses here do require confirmed exposure to alcohol. Lastly, just to show you what brain imaging is enabling us to do, we know that in the developing brain, alcohol can affect how nerve cells grow, how they divide, how they differentiate, how they group together, and this can impact how efficiently the brain can function. Brain size, the way it is formed, the neurochemistry, all of these things can also be affected or altered by exposure to alcohol. We now know that certain brain regions may be especially vulnerable to the effects of exposure. So structures like the corpus callosum, the bundle of fibers that connects the hemispheres and allows for information transfer. The cerebellum, which is supports balance and has been implicated in our ability to switch tasks and engage in tasks that involve timing and other things. We notice like a smaller brain size. So this is a brain of a child who has an FAS diagnosis. This is the brain of a child who has no prenatal exposure in their history. Both these individuals are male and they're 12 years of age. So you can really see the difference between the two brains. The diffusion tensor imaging tractography, this new imaging method that has been developed, also shows us that the communication pathways in terms of neural connections has really been impacted in the brain that has been exposed to alcohol versus the brain that was not exposed. And so again, thinking back to FASD as a brain-based disability, right? We are looking at structures that have been impacted that are not able to work as efficiently or as effectively, structures that may not be communicating with other structures in the brain in the way they were meant to. So again, when we start to experience challenges with clients, when they come in reporting challenges, come back to home base in terms of, do we need to consider whether or not prenatal alcohol exposure needs to be considered? Does an FASD need to be considered? And we'll get into some of the questions to be thinking about and asking in just a minute. Lastly, the other thing that I want to mention is thinking about FASD as a whole body diagnosis. This is now coming to the fore based on the work that people like Miles Himmelreich and other members of the Adult Leadership Collaborative have been doing. It makes perfect sense that alcohol is affecting the brain as it is developing and affecting any other organ system developing in utero at the time of exposure. And so it's really important that we pay attention to any of the health problems our clients may be expressing or experiencing, because we may end up having to do some case management. We may end up having to support clients to connect with providers, hopefully who are FASD informed. If you haven't already read the chapter, I highly recommend it. Okay. When it comes to assessment and diagnosis, unfortunately, not a lot to share about adults. There has been a lot of work done around children. A little bit more work is being done around adolescents, but adults unfortunately seem to be a forgotten population. That is changing, and there's a way to go. So at present, the diagnostic criteria for adults and children are the same, but a number of challenges to diagnosing adults have been encountered. As adults grow, they may lose the specific facial features of FAS. There may be difficulties obtaining information about alcohol exposure before birth because it may be decades in the past. There may no longer be family members to connect with to acquire that information from. People may be estranged from their families and not have this information. So these are things that I think we need to be mindful of. There may be times when we're unable to confirm prenatal alcohol exposure, which is required for one of the diagnoses. But in this case, my suggestion is to sort of proceed as if the individual is demonstrating challenges across a wide variety of domains and you're hearing certain things that are raising red flags for you, accommodating, altering your interventions to support whatever challenges the client may be demonstrating, providing them with supports, goes a long way to supporting quality of life and potentially reducing those areas of associated difficulties. So many of us come from fields that have been deficits focused, and while it is important that we understand the challenges an individual with PAE or FASD may be facing, it's equally important to identify their capabilities and strengths and to build upon and leverage these gifts. When we are able to shift our focus from a deficits-based lens, we also do things like reduce the potential for bias and negative outcomes because we are able to reframe and honor and incorporate the capabilities each client brings with them. And this ultimately leads to a more optimistic approach to support. It instills hope. It may avoid unintended feelings of shame and stigma to arise in our clients. And it's something that we can definitely look to build into our treatment planning. So as you are working with your clients, be sure to make a point of asking them what they enjoy, what they're good at, and get details about the times they have succeeded, have been successful, because we need to build on that. So in terms of areas of overall functioning, significant research has examined difficulties associated with FASD across a number of categories. So we want to sort of think about overall functioning. We often see a pattern of uneven development across several domains. You may find yourself working with a client who is 30 years old, speaks and expresses themselves well, but struggles with comprehension. When you check in to ensure their understanding of what's been discussed, they're struggling with social and life skills, and they just don't have good quality of life. Cognitive functioning is also impacted, although the majority of individuals with an FASD do have IQs in the average to above average range. We often see a real discrepancy between level of cognitive functioning and their adaptive and social and emotional functioning. So definitely something to be thinking about. Language and communication, also something that we need to be mindful of when we're doing talk therapy. And I'll come back with some suggestions for what we need to do to be mindful of how we're interacting with folks in that way. And then, the mental health challenges and the number of different comorbidities that present in individuals with an FASD. In one study, at least 90% of the people presenting struggled with mental health challenges like depression, anxiety, panic disorder, post-traumatic stress disorder, attention deficit disorder. The list just goes on and on and on. So be mindful if folks come in with a laundry list of diagnoses and nothing seems to fit. That could be another sort of flag getting you to think about what else might be happening here. When a brain-based disability is misunderstood and unsupported, Diane Malbon talked about a number of different defensive behaviors that can develop over time when there is a poor fit between the individual and their environment. And we can think about a lot of these showing up in our clients. And if we're not thinking about the brain, if we're not thinking about the challenges individuals may be experiencing, these can be interpreted as the client, just being irritable, just being frustrated, avoiding coming to therapy, making bad choices about behaviors, when really these are maybe responses to, responses and ways to cope with an environment that isn't recognizing the disability and isn't creating accommodations for it, for the individual. The associated difficulties that we often see showing up, and this is from work that was done here at the University of Washington, what really pops are the number of mental health problems that people end up endorsing suicide being a very worrisome problem, and then alcohol and drug problems being up there as well. So I do want to just give a nod to making sure that you are assessing for suicide, you are taking this seriously. The risk can be heightened when individuals experience multiple co-occurring disabilities or diagnoses. And when you're intervening, you really want to make sure that you are doing things like changing your language to accommodate for the challenges people may experience with language, with abstract reasoning. You want to be sure that you are doing things like engaging in safety planning, maybe pulling in collaterals as needed, and seeking psychiatric consultation with medication as an option. And we also know that the heightened risk for suicidality is related to increasing levels of stress, poor mental and physical health, fewer positive coping skills, and things like that. So these all become an area of focus for intervention, and again need to be tailored according to the individual's strengths and weaknesses. Really quickly, if you are working with individuals who are struggling with alcohol or other substance use issues, it really does help to have an understanding of FASD, adapting language, being flexible, being creative in the way you're working with these individuals, being mindful of the physical environment that can sometimes be overwhelming to individuals with sensory integration challenges. And we're finding that working from a harm reduction approach really does help to support individuals to make better choices. So rather than just working from an abstinence perspective, and also talking with individuals about the strengths, the challenges that impact them, and the goals they're setting for themselves in treatment.
Joanne, we're a little over the 12:30 mark, just to let you know.
Thank you. I really appreciate that. I think what I'll do is just go through a couple of things really quickly in terms of, if at all possible, getting a neuropsych eval for folks is like the gold standard, but we know that diagnostic capacity is pretty limited across many states. So we do have other things that have been developed, like the life history screen, that has red flags for you to listen for that may suggest an individual is coming in with an exposure history and may need further assessment. There's an interviewer checklist that has been developed that you can use to help organize the information you are deriving from folks to maybe help you figure out areas of challenge, strength, and again, how to incorporate this information into your treatment planning and tailoring your interventions. And then the CAN FASD folks have developed a way of approaching having conversations with folks if you suspect something and are maybe thinking that more information needs to be had in terms of finding out if an assessment is required, or what you can be doing to tailor your interventions based on the information you're receiving. Finally, we do have a diagnosis in the DSM-5 TR in terms of other specified neurodevelopmental disorder. In Canada, they think about these 10 different skills domains and look to see severe deficits in at least 3 or more of these. So this is something that can potentially inform your diagnosis of individuals. You may not be able to give them an FASD diagnosis, but you can definitely give them something that is recognized in the community from the DSM. Okay, so finally, tailoring treatment. Thanks for hanging out there with me, getting into this. So I wish I had better news for you, but the bottom line is something many of you may already know. Research hasn't caught up with what's happening in practice, and clinicians and service providers are doing their best by adapting their approaches to services and interventions to support their clients in any way possible. Current clinical wisdom for adult interventions, case management is often the approach that is most recommended, in addition to supporting self-advocacy. So we looked at the areas of challenge, and now what we need to think about is how tailoring treatment really requires us to see things differently and shift the narrative we've created around the clients we're working with. So we started out by thinking about the client who won't, is bad, is annoying, lies, whatever it is, and shifting our understanding to thinking about the client who can't, or is frustrated, or is telling stories because of memory gaps. So being able to see things differently, shifting the narrative, creates space for us to begin to reframe the challenges that the individual is experiencing and brainstorm solutions. This shift in the way we're thinking also allows us to think about the how, the alternate ways of supporting quality of life and success, accommodations that can be created to support areas of weakness or challenge, building on capacities and strengths, our clients' resilience, and how this way of thinking helps potentially to shift our emotional and behavioral responses. So I just wanted to really quickly provide you with a couple of models to sort of think about to help you develop your own neurodevelopmental lens. This comes from the work of Heather Carmichael-Olson, Families Moving Forward, where using a neurodevelopmental lens, seeing FASD as a brain-based disability provides the ability for us to reframe, brainstorm ideas, come up with approaches to addressing challenges, and create accommodations and supports for the individual. The facets model that is based on the work of Diane Malbin, I think, brings a few other things into the picture for us to consider. Remembering that all behavior equals communication of some form or another. Stopping for a moment to ask ourselves, what if the brain has something to do with what we're seeing? Comparing this information with the person's abilities and asking yourself, what does the person need in order to succeed? If you do the facets training, there's a neurobehavioral screening tool you learn how to use. Ultimately, what we're looking to ask ourselves is there a good fit between the expectations that we have for the individual, that the individual has for themselves, and their actual abilities? And if there isn't, we can just expect to see more of the same behavior, right? So we're looking to create a goodness of fit. And how do we tailor interventions to support that fit? Coming back to, is some of this behavior we're seeing really brain-based? The last model that I wanted to share with you and would highly recommend looking at this as well is the model developed by Nate Sheets, who is a behavioral consultant in Oregon. Nate bases his work on the work of Malbin. He just takes things a little further, and I really like the graphic that he provides. So we need to understand the reasons why traditional approaches to addressing challenging behaviors doesn't work. We really need to be thinking about the brain-based disability we may be seeing acted out in behaviors. We want to be thinking ahead, doing prep work to help support our understanding of our clients, laying groundwork for the work we want to do, adjusting expectations, always checking in to see if things are working or not, shifting our approach, shifting the environment, tweaking things to improve that goodness of fit, and then planning together. And I think this piece is especially important when we work with adolescents or adults and want to support agency in our clients. The last model I wanted to share with you is this ecological systems theory, where I think it's so important that we think about systems and how they impact the individual at the center, right? This creates a context within which to view the individual. It allows us to think not only developmentally, but holistically about the person, and to really be thinking about systems that are working together or in opposition to one another, and identifying systems that may be helping or harming the client. So in terms of tailoring treatment, come back to what you know, right? So many of you are gifted at what you do in your areas of specialty. So come back to thinking about the therapeutic alliance and what can be done to support and strengthen that alliance. Think about things like the task, the bond, the goals you are sharing and co-creating. Think about what it means to meet with clients in a way that is empathic, genuine, where you're offering positive regard. Keep client expectations in mind, and also think about any cultural adaptations that need to be made. So again, coming back to brain-based disability, coming back to these common factors that we know support relationships and allow us to do the work we want to do. In terms of areas of challenge, you are going to see people struggling with things like executive functioning. So being able to store information, plan, regulate their behavior, think flexibly. You're going to run into folks who struggle with thinking abstractly. So they may struggle with issues related to time, space, money, cause and effect, humor, subtlety. Verbal language processing issues may come up where they are talking almost like a professor in terms of the language they're using, but when you check for comprehension, there's a real difference between the two. So you can't assume that what is being shared is really understood. Issues with memory, challenges remembering information following verbal instructions, sensory integration issues, people experiencing difficulty modulating all of the incoming stimuli, the social difficulties they may run into in terms of reading and responding to body language, social cues, coping with stress and dealing with it in ways that are more effective. So when it comes to executive functioning challenges, do things like be consistent with appointments, schedule multiple brief sessions as opposed to one long appointment. Help your client with appointment reminders, role play situations that may be coming up for them. Use positive, immediate, and clear reinforcement. Limit changes to your treatment plans, and if change is needed, change plans carefully and model in advance any kind of problem-solving strategies a person may need. When it comes to issues around abstraction, be literal and concrete in the terms you're using. Limit your use of metaphors. Do not expect people to read into subtlety or sarcasm. Be really careful of those things. Teach and discuss generalizability, learning in one situation, generalizing it to another. And again, just make clear if something is a joke or if you are using sarcasm. When it comes to the verbal language processing challenges, learn your client's unique language patterns. Using multiple sensory modalities to process and understand verbal information may be helpful. Use simple step-by-step instructions when you are offering a plan to a client, and maybe in addition to offering written instructions for something, you illustrate them as well, or you invite your client who has a creative capacity to draw or doodle or whatever it is that is going to help make the information make sense to them. You may want to role play the client's opportunity to show their skills in this area. Be sure you're revisiting important points from each session. In terms of memory, be sure you're communicating concretely and repetitively. Make sure you're providing support for task completion, and come back and review the expectations that have been set. Don't assume that your client is going to remember, and don't get upset with them if they seem to have forgotten from one session to the next what you were talking about, what the goal was, what the steps were, whatever it is. Okay, this isn't that the client is being oppositional or not putting time into the treatment or is being lazy. Potentially it's a memory and organizational piece that we need to adjust to and adapt for. When it comes to sensory integration issues, just think about what it's like to be in a room with lights going off, phones ringing, the heater going, air conditioning blasting. It can be really challenging for folks to stay focused and stay regulated. So do your best to reduce distractions in the environment. Try to develop, create calm environments for folks to come into. And check in with your clients and get feedback from them. Trust them to be the expert. They know themselves, and it's really important that we include our clients in collaborating in their treatment planning and in their treatment. And developing that collaboration really has, it goes a long way in terms of supporting outcomes, right? We can only do that, in terms of developing that therapeutic relationship. So all this stuff comes together.
We have about 15 minutes and one question in the chat box, just to let you know.
Sounds good. Thank you. I am almost done, actually. I just wanted to say a few things about coping in terms of dealing with stress. Help your client learn how to modify their feelings when they get upset, model what patience looks like, have patience for your clients, practice relaxation and mindfulness techniques in your office, and help your clients identify activities that may reduce anxiety and stress for them. And in terms of best practices, here's where we come back to all the things I think that we know to be true. So the therapeutic environment, creating a relationship that is purposeful and collaborative, that is based on trust and a safe working environment. We want to engage in active listening. We want to be present with our clients, leverage their strengths, maintain appropriate and respectful boundaries. That may require a lot of repetition and a lot of modeling. If you can, avoid switching between providers. That can be confusing for folks and impede the development of therapeutic alliance. And I know that can be challenging for some of you working in different systems of care provision. Engage in reflection with your clients. Work with them to consider the process they're engaging in, reflect on what is working for them and what is not working. Adapt expectations as a way of decreasing burnout in yourself and your client. Recognize your own comfort level when working with clients who present with cognitive challenges and associated difficulties, especially things like suicidal behavior, substance use, and trauma. Work to become knowledgeable, work to feel comfortable dealing with issues that may present. Collaborate together on goals. Find out what is important for your client, what is realistic. And again, be thinking about this in terms of brain-based challenges the client may be demonstrating, and pull on their strengths to help accommodate some of the goals they're working towards. Explore strategies that have worked for them in the past to help support goal attainment. We've talked about the importance of adjusting language and communication to account for language processing difficulties. So be sure you're using concrete language, use specific examples, instructions step by step, and use visuals whenever possible, and constantly be checking in terms of comprehension and understanding to minimize misunderstanding. Using multiple approaches, have a toolkit ready. Here's where you get to be creative and think out of the box and maybe even tap into some of your strengths around creativity. Present information in a variety of ways. Use multisensory approaches to therapy. Engage the individual if they draw, they paint, they dance, they enjoy music. Bring all of that in as a way of helping them process whatever you are working on in the moment. Think about ways to support self-regulation and coping skills, especially grounding activities, mindfulness activities, and other sensory tools that can help increase self-regulation and a sense of well-being. Have patience, Be flexible. This work may take longer because of the need for repetition, reminders, troubleshooting, problem solving, accommodating, readjusting goals, whatever it is. But having patience and being flexible will be well received by your clients and will lead to success. It's not that individuals with PAE or FASD can't learn. They learn differently. They may learn at a different pace. We just need to learn that and create those accommodations for our clients to support them. Consistency and structure, I've already talked about. Keep your appointment times the same, if possible, be at the same location for each appointment. Maybe even have a picture of yourself on your office door so that, if your client gets confused in terms of reading numbers or gets lost really easily, there's a way to guide them to your office. Reframe the behavior. Remember, FASD is a brain-based disability. Contextualize behaviors whenever you can, right? The challenges the client may be experiencing may end up being a result of a number of things in addition to the FASD. And so thinking broadly and reframing whenever possible. I also want to say something about considering chronological age of a client versus their acts like age. You may run into these issues where a client is 30, 40, 50, and yet feels much younger. So thinking about taking that into consideration, how you're going to adjust your interventions and doing so in a way that isn't going to patronize your client, make them feel badly about themselves. So being very mindful of that, and always, always, always focus on and leverage strengths. When you can, include your client in treatment planning, and it is helpful to do things like limiting the number of treatment plans, limiting the steps involved, making sure goals are realistic, breaking them down, working at them one step at a time. Be creative about finding ways to help the client succeed. Find something the client likes to do, does well, incorporate that into your treatment planning, and reassess concepts of dependency and enabling whenever possible. I think it's also really important that we are looking to support success by doing so much of what I have talked about already, but also I think it's important to be thinking about providing trauma-informed, strengths-based, and culturally safe approaches to our clients. And so if you are not familiar with what it means to be a trauma-informed therapist, get some training in that, because so many of our clients come in with disrupted attachments, trauma histories of victimization. You need to be able to work well with that so as not to do harm. Strengths-based, I think, goes without saying, and there's a lot of really good stuff on the CAN FASD website in terms of what developing culturally safe approaches to intervention looks like, and highly recommend that you look at that, especially if you're working with Indigenous populations, BIPOC individuals. It's just something we need to be aware of. These are just suggestions, like little ticklers for thinking about ways to support success. Be concrete, be consistent, reduce distractions. These are things I've already talked about. You'll have them in the slides when they are sent to you. If you just want to print them out, have them on a sticky, just as something to sort of come back to and remind yourself of, okay, what can I do in terms of potentially creating an accommodation or altering service intervention. Things to avoid, making assumptions, implementing delayed or long-term consequences. Things like that just don't work for a lot of folks because of issues with executive functioning and memory, cause and effect. Just that's why reframing, brainstorming, creating accommodations is the way to go. If you can front load things and set the client up for success, everyone has a much better time. So rethinking the client who may have demonstrated one, if not all, of these challenging behaviors Just wondering if your thoughts about that client have changed, your thoughts about ways to intervene may have changed, maybe things you need to consider thinking about, or more trainings you want to obtain for yourselves. Just some thoughts about self-assessment. I think it's so important that we do engage in some self-reflection about the work we're doing. We need to be thinking about the content we consume and the messaging we listen to. I think we need to be thinking critically about the information that impacts our judgment and our ideas. So be sure you're evaluating the information you receive, go to evidence-based sources, seek content out from people who are impacted by stigma, bias, by FASD. Really listen to what their in-body lived experience can tell us about what we need to do to better support these individuals, to support our clients. Changing our language, being intentional and conscious about the language we're using, so that we are not engaging in judgmental language, creating harm. Shifting our perspectives on disability, and that is coming from the field of self-advocacy, making us rethink things about dependency and other things in terms of working with individuals with disabilities. And then just being able to engage in your own reflective practice, talking to a mentor, journaling, reading, reflecting on the work you're doing, the challenges you may be experiencing yourself and the successes you're having, and how that's informing the work you do moving forward. There are some lovely self-assessments available, and even assessments that allow you to look at your agencies to determine how FASD informed you really are. And with that, I thank you for your time, your attention. I threw a lot at you. Again, really appreciate the patience and you sticking with it. And I know there is at least one question in the chat. So please, if you have any questions, concerns, thoughts, there is time.
Thank you, Joanne. I kind of tried to sum some of them up and condense them. Hopefully we can get through them. I'll just go through them in the order that they were received. Are there any adolescent screening tools or assessments that can be used without a need for special training? I know you said that's a special topic and you wouldn't be touching on that much today.
Right. Yeah. So actually, there is a screening tool for adolescents. Go to the CAN FASD website. You'll find the screening tool for adolescents there, and you'll also find the life history screen. Those are two screeners. They won't give you a diagnosis, but they screen and they suggest maybe more exploration needs to be done. And both those tools do have some research behind them, so there is a little bit more validity to them, so that you're sort of grounding yourself in something that feels more evidence-based, if that makes sense. Yeah.
Thank you. We got another one that says they're curious for suggestions on how to support individuals and families with figuring out accommodations and support once they've recognized there are brain differences and the environment needs to be adjusted. They've just noticed that the families are struggling to identify what to do on their own.
Right. Oh, yeah. That's a tough one. And I think that goes back to thinking about being a really good observer of the individual's behavior and thinking about what is going on in the environment just before the behavior happens, and really noticing, like, just before, what may be happening is sort of a setting event. Is the individual tired? Are they hungry? Do they have a headache? Did they have a bad day? And, they come into the house and there's not enough time for them to transition. So there's a meltdown, right? We have to think about, what is the function of that behavior? Remember, all behavior is communication. So is the meltdown just a way of trying to avoid having to do homework, having to engage, having to take the dog for a walk, whatever it is, what would a better way for that individual to get their needs met be? Maybe using their words to say, I need 5 minutes. For a child, maybe being allowed to go and play for 15 minutes and you set the timer, having a snack ready for them. So they're able to sort of get the need met without having the meltdown. And you're creating accommodations by doing things like having the timer handy, making sure there's a snack ready, making sure that there isn't a lot of stimuli that it may be overwhelming the individual. So there's a process, and I'd be happy to talk more with you. I'll leave my contact information with Jen, and please feel free to reach out. I'm happy to consult. But some of it is sort of trial and error in a way until you find what works. But thinking about that sort of chain can be really helpful in terms of making connections with, the meltdown happens when. Here's what's going on. Here's what we need to change.
Great. Thank you so much for that, Joanne. We received a ton of compliments and comments saying how wonderful your content was today. So we really appreciate your time. I just have a couple of quick closing remarks for everyone. So please remember to fill out our evaluation survey for the webinar that you just viewed. We'll be sending that out in an email, and it's also posted up in the chat box. And be sure to join us for our next webinar on January 24th. That title is still to be determined, but we should have more information available on our website. And if you're on our mailing list, you will receive a advertisement about that. So thank you, Dr. Sparrow. We really appreciate your time and the wonderful content. And thank you to our participants for joining us today. We appreciate your time.
Thank you so much.